So good afternoon everyone. Thank you Manoj, thank you Purvi for giving the opportunity to us for presenting the important topic, that is the painful diabetic neuropathy. Patient जे पाय दुखतात तेव्हा डॉक्टरचं डोकं पण दुखतं. And it is very difficult to treat such patients. No one is satisfied, neither the doctor neither the patient. And how to manage these cases, that we are going to see. About 34% of the patients who are having peripheral neuropathy are having painful neuropathy, and it leads to sleep disturbances, reduced recreational activities, emotional distress, depression, anxiety, and that leads to poor compliance to the treatment, and in turn poor compliance can lead to deterioration of the control of glucose, and that will lead to further deterioration of the peripheral neuropathy. These symptoms are very typical as far as the peripheral neuropathy are concerned, but there are certain risk factors which can be avoided by giving proper treatment. Duration of diabetes, glycemic control, age, obesity, dyslipidemia, insulin resistance or insulin deficiency can lead to faulty signaling to the intracellular milieu, that can also lead to the progression of peripheral neuropathy, and in particular smoking and renal health. These are the two important things. Along with that, genetic predisposition, and importantly for the painful diabetic neuropathy, vitamin D levels are more also important, along with the vitamin B12 levels. So this is in nutshell the pathophysiology. We can have various drugs based on the pathophysiology, and insulin deficiency or insulin resistance can lead to faulty signaling of the insulin receptor, that can lead to various activation of various pathways. Hyperglycemia, when it enters the cell, it can lead to the activation of other pathways than the routine pathways, that is the polyol activation and all those pathways that will lead to the certain changes in the intracellular milieu. So also dyslipidemia, uncontrolled influx of the free fatty acids and the increased LDL in the intracellular milieu will lead to hypoxia, DNA degradation, and the endoplasmic reticulum stress, and that will lead to decrease in the microcirculation and the Schwann cell injury, and this in turn will lead to the faulty signaling, and that will lead to the peripheral neuropathy. So friends, as far as the neuropathic pain symptoms are concerned, either it can be spontaneous or evoked pain, and permanent paroxysmal. These are the two types of pains when there is spontaneous pain, and allodynia and hyperalgesia. Of this, the permanent superficial burning and the deep compression pain is very troublesome for the treatment, and there are various drugs which are available that we are going to discuss in the coming slide. But when to screen for the peripheral neuropathy, that is a question. As far as type 2 diabetics are concerned, at the time of diagnosis you have to search for the signs and symptoms of peripheral neuropathy. In type 1 diabetics, it will be at 5 years of diagnosis, and there are 25% of pre-diabetic patients who will complain of these symptoms, and those patients are to be searched, and there are various tests which are available. As far as the symptomatology is concerned, that gives the clue about the diagnosis, and large myelinated fiber nerves, when they are involved, we get numbness, tingling, poor balance, and decreased ankle reflexes, and the peripheral impaired proprioception. But the trouble starts when the small nerve fibers they are involved. The patient will complain of many symptoms like pain, hyperalgesia, allodynia, and there is symmetrical distal to proximal decrease thermal discrimination and pinprick sensation. So to have the tests, we have got the motor system examination along with the peripheral neuropathy. Suppose there is the muscle involvement, then that also becomes a problem as far as the peripheral injury is concerned. Large fiber sensory assessment should be done by vibration, perception sense, position sense, and light touch and pressure sensation, and pinprick and thermal sensation can also be calibrated. And there are various meters which are available. I think biostachiometer is also available, which will be accurate thing. But as far as the bedside monitoring is concerned, bedside diagnosis is concerned, we have got monofilament test, we have got the vibration perception test, pinprick test, thermal touch, and the position sense that has to be performed for each and every patient as far as the type 2 diabetics are concerned. Assessment of glycemia, lipids, renal and hepatic parameters, hemogram, and don't forget to estimate vitamin B12 levels. patients who are on long-term metformin therapy, this can be a thing which can accentuate the peripheral diabetic neuropathy, particularly a painful diabetic peripheral neuropathy. And along with that, many patients are there, particularly vegetarian patients who can be having vitamin D deficiency. Associated factors, and there are certain differential diagnoses which are to be taken into account, and for that matter nerve conduction study and electromyography can also be performed. But mind well, in the small fiber neuropathy, you are not going to get a positive nerve conduction abnormality. So that is also a pitfall as far as the peripheral nervous system examination is concerned. Distal symmetrical polyneuropathy, 50% of the patient, mononeuropathy, only 1%, less than 1%, and radiculoplexus neuropathy. These are the three categories which will present to you with the painful diabetic neuropathy. And these patients, the peripheral neuropathy, which is due to the distal symmetrical peripheral neuropathy, that is also a troublesome thing to treat. As far as the duration of the neuropathy is concerned, it might be insulin induced. When we start treatment with insulin in a long-standing diabetic patient, we get sudden drop in the blood sugar level that can lead to the small fiber neuropathy. So go slow in such cases, control the sugar very slowly to have the proper control of the sugar. Along with that, the patient's symptoms will not be there. There is the other type of neuropathy which accompanied by the poor glycemic control and ketoacidosis. In such cases, we have to control the sugar robustly so that we can ameliorate the symptoms of the peripheral neuropathy. The chronic peripheral neuropathy has been defined as pain more than 6 months, and DSPN is the most problematic neuropathy for management. Otherwise, other neuropathies are not that troublesome for management. Radiculoplexopathy, though rare, it is there. It is involved with the proximal muscle weakness and pain in the distal parts. And mind well, we have to estimate the autonomic features also. For that matter, postural hypotension, bladder bowel incontinence, erectile dysfunction, all the abnormal sweating, dryness of the skin at some places, all these histories are to be taken into account. As far as the differential diagnosis is concerned, the mechanical compressive neuropathy can be taken into account. Inflammatory, particularly due to the alcohol abuse, inflammatory due to leprosy, HIV, then the toxic neuropathy, as I told you about alcohol, and the metabolic, as far as our patients are concerned, B12 deficiency and D3 deficiency is there. So for prevention, one has to control the glycemia. Reduction of HbA1c to less than 7% has been proven to have the effect on primary and secondary prevention in type 1 diabetic people. But as far as type 2 diabetic people are concerned, the primary prevention is not a problem. Secondary prevention is problem, in which the control of glycemia is not that beneficial, and we have to target the associated factors like the obesity, dyslipidemia, smoking, and the obesity also. So we have to concentrate on these principles to start the treatment. As far as the management is concerned, 50% of the patients will not respond to the routine therapy. They will have to be subjected to some other therapy. But when we get 50% relief in the pain, it is thought that the therapy is successful. When it is in between 30 to 49%, we think that the therapy is sufficient. But one has to wait for at least 6 weeks to have the proper effect of the therapy, and one can go for the combination of treatment that we are going to see in the coming slides for the better treatment of these patients. We have got the control of glycemia and control of associated factors for the prevention. We have got pharmacotherapy. We are going to go into details in that coming slides. We can combine the therapy. As far as tropical treatment is concerned, we have got the capsaicin, which has been approved by various associations as well as the FDA, and we have got the high frequency spinal cord stimulation as the ancillary treatment to these things. There are AACE, AAN, ADA, DC, the German association, and IDF. These are the 5 associations, and they have recommended certain therapies for the peripheral neuropathy. There is no consensus about the neuropathy treatment, but as far as the tricyclic antidepressants are concerned, that is the amitriptyline, nortriptyline, they come at the first place because of their cost. So we can use them. As far as the SNRI is concerned, duloxetine is the popular compound in our practice. Gabapentin, pregabalin and gabapentin also is in practice. But as far as the American Association of Neurology is concerned, they have considered sodium channel blockers, that is carbamazepine, as a first line therapy, keeping apart the recommendation from the other associations. So opioids also can be tried, but due to the abuse, we are not going to start them at an earlier stage, though they have got a proper effect. And there are certain treatments, topical treatment, that we are going to discuss. So TCAs, SNRIs, gabapentinoids, sodium channel blockers, and the second line oral treatment will be the opioid in combination with the above treatments. As far as pregabalin and gabapentin are concerned, respectively, more than 300 milligram dose of pregabalin should not be given. Less than 300 milligram should be given, and gabapentin can be given in the dose of 3600 milligram per day. But one has to wait for at least 4 to 6 weeks to have a proper judgment of the dose. As far as the duloxetine is concerned, you can go up to 60 milligram by titrating it. 4 weeks is the duration. Amitriptyline, very popular compound, very cheap compound. You can go up to the 75 milligram dose. 4 weeks is the titration period. And nortriptyline, which has become cheaper now, can be given in the dose of 150 milligram. But mind well, for amitriptyline and nortriptyline, we have to monitor the cardiac status of the patient, and we have to wait for at least 6 to 8 weeks for nortriptyline to have a proper action. No association will recommend the opioids as the first line management. It is a desperate situation in which we are not able to decrease the pain. You can use tramadol, tapentadol and morphine also in the respective doses, and one has to wait for 4 to 6 weeks to have a proper symptomatic relief. But as soon as you get symptomatic relief, you should try to decrease the dose of opioids in any case, because the abuse is there and patients are habituated to these drugs. Sodium channel blockers, in particular the oxycarbamazepine, which is used in our area, and the sodium valproate can be used, but it is a recommendation only by one association, that is American Association of Neurologists. You can go for, you should watch for glaucoma, old age, then unsteadiness of gait, falls, orthostatic hypotension, weight gain, edema, hepatic disease and renal disease before you start all these drugs. That is very important, because orthostatic hypotension is very common with the TCAs and opioids. Tropical treatment by capsaicin 8% can be tried. It is safe, not leading to any harm to the patient. So also lidocaine can also be tried to these patients. Suppose you are not getting a proper effect with these treatments, you can go for the combination. The most popular combination is gabapentin nortriptyline in our area, so you can go for that. You can add duloxetine as a third drug, but you should wait for at least 8 weeks to have a proper symptomatology improvement in any case. So maximum dose monotherapy versus maximum dose combination therapy, you can go for either of the two depending on the patient preferences and the side effect profile of the drugs. But combination therapy in lower doses is always beneficial, because we will have lesser side effects as compared to the full dose pharmacotherapy. There are some patients who will not respond to all these treatments. So in that situation, in specialist situation, you can go for lidocaine infusion, you can go for botulinum toxin, you can go for spinal cord stimulation, and you can go for the spinal cord stimulation in any case, because that is a somewhat safer procedure as compared to the other thing. As far as the pathophysiologic based treatment is concerned, it has been observed that in type 1 diabetics, when there is pancreatic transplant which is done, it has got reversal of neuropathy at any stage. Alpha lipoic acid, then the very popular combination of B1, B6, B12 has been tried. Aldose reductase inhibitor, which has been marketed nowadays in very robustly, that is iperlastat, can also be tried. Control of dyslipidemia and hypertriglyceridemia should be done in any case. So these are some key emerging pharmacotherapies. In coming days we are going to see novel therapeutics which target the glycemia, analgesics, improved analgesics, neural analgesics, they will be marketed in coming days. So also the stem cell therapy, the gene therapy, microbiota therapy, and the new biomarkers will be marketed in recent days, in coming days. So in nutshell, you have to actively control the glycemia. Mechanism based treatment can also be tried. You can go for the individual pharmacotherapy, you can go for the combination therapy, and in some cases acupuncture also had been tried. So also spinal cord stimulation and the transcutaneous electrical nerve stimulation also has been tried. So with this I finish my talk. Thank you for the patient listening. Thank you very much.